Okay, right. Afternoon, everybody, and welcome to the second of our Positive About Down Syndrome lunchtime webinars. Today we're going to talk about the antenatal care pathway for pregnancies suspected or diagnosed with Down syndrome. I'm going to give you a brief introduction to Positive About Down syndrome if you didn't know much about us, and then I'm going to pass on to Joe and Anne, who are from St George's Hospital where the pathway was developed. They're going to give you an update on that, and then we're going to pass on to Liz, who's from the Down Syndrome Research Foundation, who's going to talk about the need for more support in pregnancy and the impact on mental health. And then we should have time for questions at the end. So Positive About Down Syndrome, if you don't know already, we're a parent-led charity, and as such we consider ourselves to be the experts through experience. We're empowering women to know what a good experience is, and so they recognise that, but we also empowering professionals to make sure that they deliver that good experience. So we want every woman to have that excellent experience in their pregnancy without being subjected to negative language or attitudes surrounding Down syndrome. We've been going nearly 6 years now, and our main role is we provide support for families, we provide information to parents and families beyond the parents and professionals. We provide a load of peer support and experts advice on bringing up a child with Down syndrome up to the age of 6. Like I said, we've only been going 6 years, so we've now expanded into primary school. We provide this kind of training to maternity units, universities, anyone will listen really. We're also involved in the Down Syndrome Act, which was passed this year. So we're part of a wider group, which is the National Down Syndrome Policy Group, which has been supporting the government in providing the support for the Down Syndrome Act. So we have a load of closed Facebook groups that you can signpost any parents that you come across with, and grandparents. So please think about us if you come across any families that need a bit of support in whatever aspect of having a child with Down syndrome. We've got our publications, which we provide for free for maternity units, the Nobody Told Me book, which is real life lived experiences, not just from parents, but also grandparents, siblings, aspirations of people with Down syndrome themselves. Little Orange Book of Knowledge is a postnatal book. Both of those you can have a look at online, and we have various experiences that we can share with your families. So one thing that we have done is we did a survey 3 years ago about how women were given the news that their baby had Down syndrome. And we do a lot of work about the impact of language when professionals are talking to women and families about Down syndrome, about having their baby with Down syndrome or have just had a baby with Down syndrome. So this is one of the quotes that we found. Are you sure you want to continue? It's just that's not what anybody else does. And that is the case, that the termination rate is has been consistently above 90% in the UK. So some professionals don't really know what to do with someone who decides to continue that pregnancy. We have found that women have told us there's poor information out there being given to them. There's a lack of support. There is some negative language surrounding giving that news that their baby has Down syndrome. And until recently, until our collaboration with St George's and the Down Syndrome Research Foundation, there wasn't an antenatal care pathway for continuing your pregnancy. There was one if you wanted to terminate that pregnancy. So that's what Joe and Anne are going to talk about today. This is the basis of the pathway, and you can access this. There's a link online to access this. So I'm just going to now pass on to Joe and Anne, and they can give you an update on the pathway. So if I stop sharing there, hopefully they will be able to jump in and share their screen.
Fingers crossed.
Yeah, fingers crossed.
It did work before, so yeah. Okay. Try that.
Looking good.
Looking good? Okay, lovely. So yes, Lou, thank you for that introduction. My name's Jo Hargrave and I am the Senior Midwife Specialist for Non-Invasive Prenatal Testing, working alongside Anne. And I've seen a few familiar faces on the participant group, so it's really great for you all to join us. First of all, what I wanted to do is just give a really brief background as to how we got to this point of providing a personalised pathway. And so I think it's really important just to sort of demonstrate the history of screening and how we've got there today. So back in the 1930s, it was recognised that Down syndrome may be related to age. Which then led to, in the 1970s, for women over the age of 36 years old to be offered diagnostic testing. Then by the 1980s and the 1990s, there was the discovery of certain markers such as hormonal and the nuchal translucency on a scan. And then here we are today, in the 2000s, where we had the discovery and application of non-invasive prenatal testing. And what NIPT is, it's basically during pregnancy, the placenta sheds cell-free DNA into the maternal blood. And by evaluating that DNA, the test is able to predict with a higher accuracy if a baby is likely to have a condition or not. And although there is currently ongoing evaluation on the accuracy of NIPT, it is very sensitive compared to the current first trimester screening. But it is really important to note that it still remains a screening test and that there are biological factors that could lead to a discordant result, or what we know as a false positive or a false negative result. And so in 2015, St George's opened a laboratory dedicated to non-invasive prenatal testing because we were seeing that patients were having their higher chance combined screening and going off to private services to have NIPT because it wasn't available locally. And with doing that, the team recognised that clinicians needed support within practice with the education and communication and resources for their patients, which led to a project of developing my role and Anne to where we are today. And I'm not sure if Nicola's on the call, but in 2019, through a neutral person, Nicola contacted our team to highlight what women and families were reporting in practice, that there were concerns around the access to care, especially for women who had decided following an NIPT result that they didn't want to have a diagnostic, they would prefer to continue without that diagnosis. But there was also concern with the stillbirth rates within the community. And then looking at my own experience of working in fetal medicine, I had seen women from the moment of deciding whether they wanted the offer of screening to the point of diagnosis and the discussion of ending a pregnancy or continuing a pregnancy. And although we felt that we provided good quality care to those patients, there were still gaps for both those who wanted to continue or end a pregnancy. And so we were asked to work collaboratively with PADS and the Down Syndrome Research UK to produce a pathway for those women with the aim to support women's choices and provide a framework for care to guide clinicians. And so I want to thank Professor Baski Vilaganathan, who provided the obstetric medical side of the pathway, to Angie Bowles and myself, who provided the midwifery side of the pathway, to Sarah Costerton and Nicola Egnock, and also Liz Cockram to provide the patient side, patient voice, and also the psychological implications. So it was really a good MDT approach, especially with the inclusion of the patient voice. And here we are. It took a year and it was shown by Lou, but here's a link on this PowerPoint as well to go directly to the pathway. And the aims of it was to provide continuity of care and support to those patients. The ideal would be a named person or a team of midwives to support the patient through their pregnancy. And the evidence through sort of better births is that this is the preferred model of care by patients, because it brings trust, a trusting relationship between the medical professionals and the patient. And it also allows women to be empowered to voice their concerns. We also recognise that with that continuity of care, it can reduce the rates of preterm birth and fetal and neonatal deaths. But it's also really important to highlight, although continuity of care is really important, so is the fact that other comorbidities or high risk concerns such as high blood pressure in pregnancy require a need for further pathways and specialist care. We then also wanted to ensure that there were appropriate referrals made for structural complications, prematurity, and placental dysfunction. So we recognise that actually there should be a detailed scan at around 18 to 22 weeks, because we know that there are associated conditions with Down syndrome, such as heart, renal, bowel conditions. And so it's really important to establish what they are as early as possible, to put recommendations and care in place. Prematurity is mainly to do with polyhydramnios, which is related to bowel problems. And again, linking back to that continuity of care, by having that really good relationship, women are able to kind of voice their concerns to the professionals. And I also think as midwives, we have that instinct of seeing a patient on a regular occasion to recognise when there are changes for that woman. We then look at placental dysfunction. We know that there's a risk of the placenta being unable to supply adequate oxygen and nutrients to the baby from the mum. And so that can lead to growth restriction, miscarriage, and stillbirth. And there's also that indication of reduced fetal movements. So we wanted to add in extra scans that should be done around 28 weeks and 36 weeks. And this is to highlight that risk of growth restriction. And if that is then identified, those patients should then be followed up with the appropriate guidelines for intrauterine growth restriction. We then moved on to the psychological concerns. I don't know about you, but I've seen many women come through the service with many anxieties about not only the baby, the bonding with the baby, and the risk of stillbirth, but also the social implications and sort of feedback. So it was really important for us to make sure that there is that support out there. We also found that some people felt guilty. They blamed themselves for this condition, but you know, at the end of the day, it's trying to bring that reassurance of actually we can provide very good high quality care for the mum and her baby. So it's really important to signpost to professional organisations, and I hope that Liz can talk more about the sort of psychological implications for women. And then finally, we wanted to ensure that there was a smooth transition into postnatal services. And we felt that there should be an overlap of care and links to the neonatal teams prior to birth, so that there could be a clear pathway to support the women through the delivery and postnatal care. And then finally, with breastfeeding, this was something that was really important to women, actually, is noting the challenges with low muscle tone and how we can support women in preparation for birth and aftercare, such as colostrum harvesting. And so we've been, using this pathway for 2 years, and I hold my hands up. I no longer work in fetal medicine, so I felt it was only right that we should pass over to someone who has used the pathway in practice to kind of talk about the benefits and challenges. And this pathway, as I say, has been running for 2 years, so it is up for review to see if there are any further improvements to be made. But I shall now pass over to Anne, who will provide her view on using the pathway. Thanks, Anne.
Thanks, Jo. So I'll just introduce myself. As Jo mentioned, I'm an NIPT Senior Midwife Coordinator working with Jo at St George's, but I do also work in the fetal medicine unit as a midwife half the time as well. And just to give you a very brief kind of overview of what I do as a fetal medicine unit midwife, I counsel women that receive a higher chance combined or quadruple screening result and discuss their options for further testing if that's what they want. And I counsel and consent for non-invasive prenatal testing, diagnostic testing, so CVSs and amnios, for example. And then also it's my responsibility to give the results of that testing to women, and then to ensure that they receive the appropriate, support and care once they've received a result, whether that be continuing their pregnancy or whether that means ending the pregnancy for them. And so I'm just going to talk briefly about sort of my experience of using this guideline in practice, and also our sort of what we're doing at the moment, which is actually an audit of that guideline as it's up for review. Next, please, Jo. Lovely. So first of all, I just wanted to talk about really some of the positives of using this personalised guideline for women continuing a pregnancy. First of all, it's a really empowering tool for midwives, actually. We know that it's actually a relatively small number of women that we might see each year that do choose to continue a pregnancy, with a diagnosis or suspected Down syndrome. And what that really means is that actually for a lot of midwives, they may not really be familiar with looking after women who have made that choice and what is appropriate care for them. So having that guideline in place at St George's really empowers us midwives to know what we should be offering women, and making sure that they do get that care and support that they need. It's also, of course, a real tool to prevent those poor outcomes that we never want to see for mums and their families and babies. And obviously we do know, as Jo's mentioned, that there are some associated structural complications with Down syndrome and the increased chance of prematurity and stillbirth. So we can really use this guideline as a tool to try and minimise those risks where possible. And I suppose, when it comes down to it, it's a way of preparing and empowering women, for the journey ahead of them, and we can use this guideline as midwives to support them in that journey, and hopefully we're removing some of the obstacles that they may have experienced in the past. Next, please, Jo. There are some challenges, when we're using the guideline as midwives, or when we're looking after women that have chosen to continue a pregnancy. I suppose it can be sometimes difficult to strike the right balance between making women feel that they are receiving the routine care and enjoying their pregnancy in the way that any woman who is pregnant should be able to enjoy their pregnancy. So sort of not making them feel like they're special cases, this is a very different thing, whilst also making sure, of course, that we are offering them the additional care that's going to keep mum and baby safe. So it's just about finding that right balance when we're looking after women. Obviously, one of the kind of primary tenets of that guideline is that we offer continuity of care to women. And in the case of St George's, we offer all women who are continuing a pregnancy to be caseloaded by the fetal medicine unit midwives, of which I'm part of that team. And you know, we really hope that that's going to help them. But we also have to be kind of realistic and open and transparent with women about you know, the time and resources that we can offer them. So we absolutely, as a bare minimum, want to offer them you know, everything that is contained within the guideline. And we want to be that kind of resource so that women can always ring us, speak to us, see us if they've got any worries, any concerns. But sort of like everywhere in the NHS, we're a bit bound by the time and resources that we have and the staffing that we have, which is a real challenge, you know, across the whole of the NHS. I suppose another challenge that we might face, and as you know, has been mentioned, is, you know, using the right language, unbiased language, not bringing our biased attitudes or language. I hope at St George's, particularly in the fetal medicine unit, that we are quite good at that. But we do know that some women, you know, may come to us already having had the experience earlier down the line in their pregnancy journey or in their screening journey of having already met some, you know, attitudes that aren't helpful, or having heard language that is not helpful to them. So we do see it as part of our role, really, to kind of educate all of our colleagues in the multidisciplinary team, and the guidelines are a really good tool for that as well. And I suppose another challenge for us in using it is making sure that we're reaching out to some of those traditionally excluded groups. So, for example, women that don't have English as a second language, and, you know, perhaps asylum seekers, travellers, you know, particularly at St George's, which is in South London, we're looking after a really, really diverse population. So the guideline is a great tool, but we've got to make sure that it's also really accessible to all those groups as well. Next slide, please, Jo. As Jo mentioned, the guideline's been in use for 2 years now, and it is up for review. So we really wanted to kind of make sure when we reviewed it that we were kind of certain, or as certain as we could be, that it really is doing what it's designed to do. We're really hopeful that this is a really good guideline, but obviously we should never make assumptions that it is perfect, that it is working completely. So we have decided to do an audit, which is in process at the moment, of the guideline, to try and assess, you know, whether it is doing what it's designed to do. And we're really hoping to get feedback from women for whom this guideline is relevant, and to really kind of hear their voices. And we're going to specifically speak to women that have their care at St George's. And, you know, by doing that, we can also kind of cross-match their recollections and the feedback they give us with actually their maternity records as well, to make sure that the guideline was followed appropriately, and to see if there's anything that we're missing with the guideline, anything that we could be doing better. Obviously, when it comes to changes in clinical practice, in terms of what's recommended with the guideline, that really needs to be based on wider evidence. But certainly, we would be very happy to hear the feedback of women, and if there's, you know, things that are consistently coming up about, you know, what they feel we could be doing better, or what might go into the guideline to improve their experience, it's certainly something we want to take on board. So that is our aim of the audit that we're carrying out at the moment. Next slide, please. One of the particular challenges of the audit, I suppose, as I previously mentioned, is that in reality, you know, it is quite a small number of women that are opting to continue a pregnancy with Down syndrome or suspected Down syndrome following a higher chance NIPT result. And at St George's, we have about 5,000 births a year, and probably approximately 5 to 10 women each year that opt to continue a pregnancy with Down syndrome or suspected Down syndrome. So that's quite a small number of women that we are hoping to get feedback from. And obviously we may not be able to, for a variety of reasons, actually get feedback from all of those women. So what we've decided to do in terms of that audit is actually really expand it to get feedback from women throughout their screening journey. So we are going to ask feedback from women that have received a higher chance combined or quadruple result, from women that have received a higher chance NIPT result, those women that have gone through with prenatal diagnostic testing for trisomy 21, 18 or 13, and then of course those women for whom the guideline was designed and those that have continued their pregnancy. And we're hoping by doing that, that really we can take in the whole screening journey and get experience of women at all those different stages of their journey, because we know that all of that will have fed back into the decisions that women are making during their pregnancy and how they feel about those decisions that they've made and the care and support they've received at each step. So that is our aim, and we're hoping sort of in early next year to start getting some feedback from women to see how we're doing in terms of following the fetal anomaly screening programme guidance, and obviously the actual personalised guideline as well, and then to act and review from there. Next slide, please, Jo. So I just wanted to thank everyone for listening today. I suppose I just want to summarise by saying we really hope this guideline is making a difference for women, and even if it's made a difference for 1 or 2 women at St George's, if it saved 1 baby, or it's reduced some of the more difficult aspects of what women used to experience going on this journey, then that is what it's there for, and we're hoping we can only make it better. So thank you very much. I'm going to hand over actually now to Liz, who's going to talk a bit more about the mental health and support aspect.
Thank you, Anne. I appreciate hearing about how it's been going since we were a part of those initial days when the guidelines were created. So my name is Dr. Liz Corcoran. I am the chair of the Down Syndrome Research Foundation UK. I'm also a psychiatrist, and I'm also a sister to an adult with Down syndrome. So that's my conflict of interest, right? I wanted to be involved with this guideline for a long time and was very excited when Nicola managed to get the connection with St. George's and that they were interested also in making this happen. Why did we care about this? Why did, as a research foundation, why did we think this was important? Well, because we know that healthcare professionals need support. We know that you guys are doing a really hard job and that you deserve to be guided by the best and most up-to-date evidence. And if people don't write those guidelines, then how are you supposed to know what's the best thing to do? You are under the pressure of a long list every day of women to see and questions that need to be answered. And you deserve to have good guidance that's written based on up-to-date evidence. So that was why when the team at St. George's were interested, we were very willing and snapped off their hand the chance to be involved in this. Why does it take so long for research to change practice? I don't know. The recent study said up to 15 years between research studies changing things in the clinic rooms. It's too long. And everywhere we can create the shortening of that time, we should do that. So we know that when evidence is actually implemented and changes practice, that outcomes are better. And we all want that for our patients. We want people to, when they want to continue that pregnancy, to have a successful pregnancy. We don't want them then to have the tragedy and grief of stillbirth, of a much wanted pregnancy. So why does it matter that a parent, from their point of view, that there is this guidance available? Obviously, Joanne and Anne have talked a bit about the different parts of the guidelines, right? Talking about picking up the issues with fetal growth and structural issues and placental dysfunction. Yes, that's all extremely important. And those things need to be picked up in a timely manner so that they can be monitored appropriately. But there is also this important aspect of getting it right for the psychological support of the woman and the partner throughout the pregnancy. I'm sure you guys have had lots of training about postnatal depression and issues of social isolation during pregnancy and how that impacts the woman after delivery. But hopefully also they've talked to you about the impact that also has on the fetus. A stressed woman does not, it is not a healthy pregnancy, right? Not only for herself, having elevated stress hormone levels throughout pregnancy not only causes issues with her health, physical and mental health, but also the fetus is washing in those stress hormones throughout the entirety of the pregnancy. And we now know from research done on pregnancies not affected by Down syndrome, but other pregnancies, is that those fetuses then develop into children that have higher rates of issues with development and more challenges around parenting. And actually on into adulthood, there are markers there with issues of chronic health problems. So getting it right from the beginning is so, so important. We cannot understate that. And how can we do that? You guys aren't there with your magic wands. You're not able to sort of magic away all the problems that women face. Of course not. But we can't take away these things, but we can help people to connect with others that have gone through these things before, right? So reducing the social isolation is incredibly important. And frequently, what we recommend people do is to get in touch with Nicola's charity, Positive About Down Syndrome, where they have a number of peer-to-peer support networks, and they also have professionals who help support and supervise those groups, such as the Great Expectations Facebook group, in addition to the professional support groups that are there as well for you guys to talk about your difficulties and how you can better support the women in their situations. Being able to help people navigate those early days is very, very important as well. Now, as I said, you can't magic away the difficulties, but you can help them to connect with professionals that can answer their questions and help them to begin to get a little bit more certainty about some of the things that they may have heard. We obviously want to live in a society that is welcoming of diversity, that is open to all kinds of human beings that are out there, but we have to accept that that doesn't exist at the moment, where that's something we're striving for as humanity. And there are a great number of value judgments that exist around Down syndrome. And the woman in front of you will be coming into the room loaded with some of that. Maybe everything she's ever heard about Down syndrome has been negative. And something that you can do is help to illuminate and give them the most up-to-date information about what life with Down syndrome in this century is actually like. So connecting them with peer-to-peer support groups and groups such as ourselves and Positive Down Syndrome can help you to do that. We know from research, unfortunately, they did a survey of 1,250 women who had infants with Down syndrome and found the majority had negative encounters with healthcare providers during the time of diagnosis. Now, that wasn't done in the UK, and I hope that we would do better in the UK. But we know that there's common factors that people want. They want support, education, and guidance on the long-term management of their child's needs in the future. And that's where a multidisciplinary team comes in. And we hope you will see ourselves, Positive About Down Syndrome, as a part of that team so that we can help you to create an environment around that woman and her family to begin to support them, to reduce social isolation and create social connection, and help them have that sense of understanding and empathy to help reduce that stress that they are going through during that time of diagnosis and during the time where they await their baby's safe arrival. So I will hand over back to Lucienne and just encourage you all to get in touch if you would like to bring these guidelines to your maternity unit, to think about how you can do your part to help improve outcomes for pregnancies affected by Down syndrome in your area as well. So thank you, Lou.
Thanks, Liz, and thanks, Joe and Anne. This has been really, really helpful. So I'm just going to quickly share my screen. If you want any more information from Positive About Down Syndrome, we have a copy. We can send you the link for the George's Pathway, but as Liz's been saying, if you want to signpost any of your mums to us, the Great Expectation closed Facebook group has also got the admin consists of 2 midwives and 2 neonatal nurses who are both parents of children with Down syndrome. So the emotional support that they get is really specific. I mean, amongst other people, there's other people that on the admin, but and also you might want to consider joining our closed Facebook group, which is the for magnificent, marvelous midwives. That's not just for you know, practicing midwives, student midwives are very welcome there too. If you wanted any copies of our online literature, there's the links there. So I think we have a little while for questions. I'm going to stop sharing. We're recording this session that we can pass on to you if you've registered for this meeting. And there was a question of whether we can share the slides. So that's a question for Anne and Joe to answer. But if you have a question, you can raise your hand and I think we can unmute you, or you can unmute yourself. Is there any questions?